plus the lateral epicondyle. Okay, so the capitulum plus lateral epicondyle together makes the lateral condyle of the humerus, whereas trochlea plus the medial epicondyle makes the medial condyle of the humerus. Okay, so here the question is talking about the fracture of lateral condyle of the humerus, whether it is an intra-articular fracture or an extra-articular fracture. What do I mean by this term? Articulation का मतलब होता है joint. So intra-articular मतलब a fracture within a joint. Extra-articular मतलब a fracture outside a joint. So lateral condyle fracture humerus कौन से type का fracture है? It is a intra-articular fracture, and all intra-articular fractures are fractures of necessity. Shabash. And what do I mean by fractures of necessity? Which type of surgery? PORIF, that is open reduction and internal fixation. So the types of fracture where always and always open reduction and internal fixation will be the treatment. Such types are called as fractures of necessity. There are three types of fractures. First, all intra-articular fractures. Okay, first one are all the intra-articular fractures. Second, one specific example is lateral condyle of fracture, lateral condyle of humerus. And third, your fractures of forearm bones. Which are the two forearm bones? The radius and the ulna. So their fractures, that is together called as Montague and the Gagliardi fracture dislocation. Okay? Those are also considered to be fractures of necessity. Yaad rakhna hai bhai. Chalo, moving further. Gradually developed cubitus valgus deformity in the elbow. I have given a straightforward. So due to lateral condyle of humerus fracture, I hope all of you are quite aware, the child develops a cubitus valgus deformity. So now you can see in the long axis of the arm and forearm, normally there is an angle. What is this angle? It is how much? It is 11 to 14 degrees. Okay, the normal angle, it is called as the carrying angle. So normal carrying angle kitna hota hai? So the normal carrying angle is around 11 to 14 degrees. Okay, it is around 11 to 14 degrees. Please remember, when the angle increases to more than 14 degrees, when the angle will increase to more than 14 degrees, then this is what is called as cubitus valgus. याद रख लो जब डिस्टल पार्ट लैटरली जाता है, दैट इज व्हाट इज वाल्गस. वाल में एल आ रहा है ना, एल फॉर लैटरल, प्लीज रिमेंबर. ठीक है, सो व्हेन द डिस्टल पार्ट गोज लैटरली, दिस इज वाल्गस, एंड व्हेन द डिस्टल पार्ट मूव्स मीडियली, दिस इज वारस. क्यूबाइटस का मतलब होता है एल्बो, जीनू का मतलब होता है नी, कॉक्सा का मतलब होता है हिप, एंड हैलक्स का मतलब होता है टो. ठीक है, टो तुम्हारा ग्रेट टो वगैरह. So that's the important thing. So here, as they are talking about cubitus valgus deformity, that means it is this kind of a deformity where the forearm is moved laterally. ठीक है, and why does this happen? Because there is a fracture of lateral condyle of humerus. अब क्या होगा यहाँ पे? There would be loss of some fragment. Therefore क्या होगा? छोटा हो जाएगा lateral condyle, right? Due to loss of some fragment from here, the lateral condyle would be smaller. And lateral condyle small हो जाता है, उसकी वजह से और क्या होता है? यहाँ पे growth होती रहती है normally. So therefore the medial condyle will grow in size, but the lateral condyle does not grow in size. तो अगर lateral condyle grow नहीं होगा, बस medial condyle grow होता रहेगा, तो क्या होगा? Distal portion will be pushed outwards. That is cubitus valgus deformity हो जाएगी. ठीक है, और ये क्यों हो रही है? Due to growth of the medial condyle of the humerus. Due to growth of the medial condyle of the humerus, ये term याद रखनी है. Due to growth of medial condyle of humerus. What is the likely outcome in this patient? तो क्यूबाइटस वाल्गस क्यों होता है? ड्यू टू ग्रोथ ऑफ मीडियल कॉन्डाइल ऑफ द ह्यूमरस. अब कुछ याद आ रहा है? Just behind the medial epicondyle or the medial condyle of humerus, which nerve passes? It is the ulnar nerve. ठीक है, ulnar nerve passes behind the medial epicondyle of the humerus. अगर क्या हो रहा है यहाँ पे? There is growth of this medial condyle or medial epicondyle, due to which what will happen? Now this overgrowing medial epicondyle can compress the ulnar nerve, but ज्यादा compress करेगा क्या? अचानक से नहीं करेगा. It will not cause a sudden palsy, rather it will cause धीरे 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 a gradual one. This is what is called as tardy ulnar nerve palsy. Okay, chalo. So due to the overgrowth of the medial epicondyle of the humerus, the patient will develop a complication that is called as tardy ulnar nerve palsy. Okay, tardy ulnar nerve palsy. So now let's see what is the feature of ulnar nerve palsy in this question. Option A says Kilo-Nevin sign, also called as which sign? Anybody? Kilo-Nevin sign is also known as the OK sign. So if you need to perform this action in between your fingers, the OK sign. OK sign के लिए क्या करना पड़ रहा है? You need to flex your thumb and your index finger. You need to flex the thumb and the index finger. Flexion of thumb is carried out by flexa pollicis. ठीक है? And flexor of index finger is called a flexa digiti indicis, right? Or the flexor digitorum profundus. ठीक है? और flexor digitorum superficialis. इससे flexion होता है. ठीक है? तो ये दोनों के दोनों मसल्स कौन सी नर्व से इनर्वेटेड होती है? It is the median nerve. So if the median nerve of a patient is injured, will the patient be able to perform this OK sign? No. There would be weak OK sign. He'll not able to perform this OK sign because these flexa muscles are parallel. And therefore, this weak OK sign is also known as Kilo-Nevin sign. It is a feature of what? Median nerve injury. So that's rule. Option B says pointing index sign, also known as Ochsner clasp test. So you ask the patient to actually make a fist or to make a clasp, okay? But even after that, what happens on the affected side? This index finger, it remains prominent. It is not able to flex. Okay? This is what is called as the pointing index sign. Please remember, why this finger is not able to flex? Abhi bola, kaun si do muscles hoti hai flexion ke liye? FDP and FDS. ठीक है? So FDS joins at the, last time बताया था, middle phalanx, and FDP joins at the distal phalanx, and they help in flexion. ठीक है, नाम में ही उनके फ्लेक्सर, तो दे हेल्प इन फ्लेक्शन. सो FDP and FDS of this patient has been paralyzed, and therefore flexion of the index finger is not possible, and both these muscles are innervated by the median nerve again. Therefore, pointing index sign is again a feature seen with median nerve injury. This was the easiest one. If a patient is having wrist drop deformity, what do I mean by this? Wrist drop, matlab the patient is not able to perform which action at the wrist? It is एक्सटेंशन को क्या बोलते हो? वेरी गुड, एक्सटेंशन. ये अबडक्शन कहां से हो गया बच्चों? ये अबडक्शन कहां से हो गया? अगर ये अबडक्शन है तो ये क्या है फिर? ये क्या है फिर? दिस इज व्हाट इज अबडक्शन, दिस इज व्हाट इज अडक्शन. ठीक है, दिस इज व्हाट इज फ्लेक्शन, और वी कैन कॉल इट, कौन से साइड पे फ्लेक्शन है? पाल्मार साइड पे ना, तो पाल्मार फ्लेक्शन. दिस इज कॉल्ड एज एक्सटेंशन और dorsiflexion. dorsum पे flexion है ना, तो this is what is dorsiflexion. So question में वो mention करेंगे there is loss of dorsiflexion. Why I'm making you understand? Because in question they'll not write wrist drop, they'll write the patient is unable to perform dorsiflexion at the wrist. ठीक है, and dorsiflexion is this action. So if the patient is unable to perform dorsiflexion, that means he's suffering from which deformity? Wrist drop deformity, which is a sign of nerve injury, radial nerve injury, because all the extensor compartment of arm, forearm and the hand are innervated by the radial nerve itself. So again, this is ruled out. What is left? Adduction of the fingers. I hope all of you are quite aware. Last time मैंने discuss किया था. Adduction of fingers is caused by which introtia? Palmar introtia. And abduction of fingers is caused by which introtia? Dorsal introtia. Mnemonic क्या था उसका? Pad and dab was the mnemonic, right? And all these, all these 8 introtia are innervated by which nerve? Because these are intrinsic muscles of the hand. Therefore, all of them are innervated by the ulnar nerve itself. Therefore, what will happen if the patient has developed a tardy ulnar nerve palsy? The patient will be unable to adduct the fingers. या adduction नहीं हो पाएगा fingers का, ठीक है? So that's a basic thing. No issues with this. And if a patient is having ulnar nerve palsy, which is the kind of splint that you will give to the patient? Splint. Shabash. It is the knuckle bender splint, which will cause flexion at the metacarpophalangeal joints or at the knuckles. That is what is called as the knuckle bender splint. Okay, that's the important funda. Rule out. अगर नहीं समझ में आ रहा था तो हम rule out भी कर लेते ना. You would have been able to answer this question. No issues with this, anybody? That's the important one. And this was about lateral condyle of humerus fracture. तो याद रख लो, lateral condyle of humerus fracture causes which deformity? It causes cubitus valgus deformity. And which nerve palsy? Ulnar nerve palsy. Another fracture which is close to it. What is this? यहाँ पे fracture होता है बच्चों में. Above the condyle. Very good. It is the supracondylar fracture of the humerus. But if a patient is having supracondylar fracture of humerus, patient has this kind of a deformity. What is this known as? Gun stock deformity. And gun stock deformity में क्या दिख रहा है? Distal fragment, distal part of the limb is inwards or outwards? It is inwards. एंड इनवर्ट्स होगा तो क्यूबाइटस varus deformity is there. ठीक है. So supracondylar fracture humerus causes a cubitus varus deformity or known as gun stock deformity. No issues with this anybody? That's important thing. And उधर कौन सी nerves paralyze हो सकती है फिर? There can be chances of radial nerve or medial nerve injury over there. ठीक है, याद रख लो ये बात. ulnar nerve के बारे में I feel I'm not sure. Last time I said कि cubital tunnel में से पास होती है. So in cases of cubital tunnel syndrome, which nerve is paralyzed? It is the ulnar nerve which is paralyzed. But cubital fossa अगर वो mention करेंगे तो कौन सी nerve होगी? मीडियन नर्व होगी या रेडियल नर्व हो सकती है. दोनों नर्व्स पास करती है क्यूबाइटल फोसा में से. क्यूबाइटल टनल यहाँ होता है. एंड क्यूबाइटल टनल इज बिटवीन विच मसल? फ्लेक्सा कार्पाई अल्नारिस, नाम में ये उसके. whereas median nerve passes in between two heads of the pronator teres muscle. ठीक है, याद रख लो. चलो, moving further. So that was about your median nerve injury. Please remember, median nerve innervates which eminence? Thenar or hypothenar? Thenar eminence, the part below the thumb. And which fingers? Lateral 3.5 fingers are innervated by the median nerve. This is on the palmar aspect. Dorsal aspect पे tips of the lateral 3.5 fingers are also innervated by the median nerve. ये tips जो होती है ना, पीछे से median nerve ही supply करती है. Please remember that. Now, if the patient is having median nerve palsy, there would be atrophy of these muscles, right? Denervation atrophy हो जाएगी. Therefore, there would be wasting of the thenar muscles in this patient, except one thenar muscle. Adductor pollicis, because it is innervated by the ulnar nerve. Shabash, that's important. Okay? The wasting of thenar eminence can be seen in this patient. Along with that, this is the Kilonevin sign. As you can see, there would be a weak OK or the Kilonevin sign in the patient. Loss of sensations from the lateral 3.5 fingers. Okay. Along with that, when you ask the patient to make a clasp, this is known as the Oshner clasp test or the pointing index sign. Okay. Next is what? This is the reverse phalanx test, and this is what? Phalanx test. Okay. Better one for median nerve injuries, the reverse phalanx, but you can perform both. Okay. Reverse phalanx as well as the phalanx test. Both can be done for median nerve injury. Then third is the pen test. So if I keep a pen and I ask the patient to touch this pen, ठीक है, with the help of his thumb, तो उसको क्या करना पड़ेगा? thumb is going away from the center, so it is what? Abduction. So abduction करके touch करेगा वो. But as the patient's median nerve has been injured, abductor pollicis muscle has been paralyzed, will the patient be able to touch this? No. So this is what is called as a positive pen test. ठीक है? And this is the pointing index sign. What is this deformity in median nerve injury called as? Ape thumb deformity. Why? Because thumb has a special function of opposition, given by which muscle? Opponent's pollicis. But as median nerve injured, again there would be paralysis of the opponent's pollicis muscle. तो ये action हो पाएगी क्या? नहीं. Therefore the thumb will come to lie in the same plane as all the other fingers. जैसे पूर्वजों के टाइम पे था. That is what is called as the ape thumb deformity. Please remember this. Then what is this? This is known as the Pope hand or the benediction hand deformity. Please remember. That will happen due to palsy of which muscles? Lateral flexor digitorum profundus and flexor digitorum superficialis, because flexion of these lateral two fingers is not possible. Therefore, these will not flex. Okay, this is what is called as the benediction hand deformity. No issues with this. Flexion के लिए तीन muscle काम करती है, याद रखना important. First is definitely the FDS, second is the FDP, and third are the lumbricals, and all of them will be paralyzed because all of them in the first and the second finger are supplied by the median nerve itself. ठीक है, याद रख लो ये बात. Moving further now, talking about question number 2. हाँ, क्या ये phalanx टेस्ट होती है उल्टी वाली, और ये रिवर्स phalanx टेस्ट होती है. ठीक है, नमस्ते वाला is a reverse phalanx test, and that is also done. Reverse phalanx test is specifically done in a case of diabetic cheroarthropathy, that is a complication associated with diabetes. Okay, जहां पे patient नमस्ते नहीं कर पाता ढंग से due to the involvement of his bones and the nerves in the hand. ठीक है, so that's the important thing that you will study in medicine now. Question number 2. लैटरल एपिकोंडाइल के पीछे तुम्हारी रेडियल नर्व पास होती है. ठीक है, लैटरल एपिकोंडाइल पे नहीं होती वो. यूजुअली इट गोज इन द क्यूबाइटल फोसा एंड देन वो पीछे टर्न करती है. ठीक है, इट गोज, सो इट कम्स फ्रॉम बैक साइड, इट एंटर्स इनटू द क्यूबाइटल फोसा एंड इट अगेन गोज बैकवर्ड्स. ठीक है, so that is the radial nerve in close relation to the lateral condyle of the humerus. ठीक है, but not exactly in contact, just like the median nerve. ठीक है. क्वेश्चन नंबर 2 नाउ, और इसमें क्या ट्रीटमेंट करोगे टार्डी अल्नार नाउ पैल्सी में? यू विल जस्ट ब्रिंग द अल्नार नाउ इन फ्रंट ऑफ द मीडियल एपिकॉन्डाइल, बिकॉज as it was posteriorly therefore it was getting compressed, तो क्या करो आगे लाओ बस उसको. Question number 2, what is not required in emergency management of an open femur fracture? I hope all of you are quite aware fractures can be classified as two types, open and closed. What do I mean by open? Open fracture, also called as compound fracture, where the hematoma which is formed at the fracture site that will communicate with the external environment. Whereas a simple or a closed fracture is the one where the hematoma is not communicating with the external environment. If I talk about open fracture में chances किसके ज़्यादा होते हैं? There would be high chances of infection. Very good. That's the important thing. ठीक है? And in open fracture there can be loss of soft tissues also. क्यों? क्योंकि bone directly बाहर आ जाता है. So there can be a loss of soft tissues also. So you might require a flap for coverage. ठीक है? So what is the classification used for open or compound fracture? Naam? Shabash. It is the Gustello and Anderson's classification. So if I talk about the Gustello and Anderson's classification for open fractures, please remember, type 1 fracture matlab one size less than 1 centimeter. Type 2 fracture matlab one size between 1 to 10 centimeters. Type 3, now type 3A matlab one size more than 10 centimeters, and there is enough of soft tissue coverage which is available. याद रख लो, soft tissue का loss नहीं हुआ है. Type 3B matlab wound is more than 10 centimeters and we require what? We require a soft tissue coverage. मतलब there have been loss of soft tissue, तो तुम्हें soft tissue coverage की जरूरत पड़ेगी अभी. And lastly, type 3C, it is vascular injury. ठीक है? If there is a injury to the vessel, artery or vein, definitely that would be considered as type 3 Gustello-Anderson classification. Now if I talk about open fracture management, open fracture की management किससे करी जाती है? Anybody? Open reduction करोगे definitely, but external or internal fixation? So classically याद रख लो, बाकी भी चीजें करते हैं हम, इसीलिए एक्सेप्शन पूछा है मैंने. I have asked you which is not required. So that means बहुत सारी चीजें करी जाती है, but the best one to be done is open reduction and external fixation. Reason is open reduction तो करोगे तुम, external fixation क्यों करना है with the help of rods or pins? The reason is, please remember, as you will insert something inside, there would be high chances of infection. Therefore always go for a external fixation as much as possible. But अगर external fixation possible नहीं है, then you might need to go for an internal one as well. So then open reduction and internal fixation कब? कौन से केसेस में? फ्रैक्चर्स ऑफ नेसेसिटी. ठीक है? In fractures of necessity, whether it is an open fracture or a closed fracture, you always need to go for ORF. तो उसमें करोगे. Then if I talk about antibiotic coverage, will you give antibiotic coverage? Yes, you will give antibiotic coverage. What is not done? Definitely you will not go for, sorry, please remember, ORF की अगर मैं बात करूं, इसमें अगर मुझे बेस्ट चॉइस चूज करना है, ORF हम इंट्रा आर्टिकुलर फ्रैक्चर्स में जरूर करते हैं. But the problem is, if it is an open fracture, now what we do for some time, at least we'll go for an external fixation. We'll give antibiotics to the patient. We will let the infection resolve, and then we'll go for a ORF in the patient. ठीक है? तो immediately तुम ORF नहीं करते हो until and unless the infection will be resolved in the patient. या फिर prophylaxis देते हो antibiotics का at least for a span of 2 weeks, and then you will go for a ORF. तो इसमें अगर बेस्ट आंसर देखना है तो ऑप्शन बी से क्लोज रिडक्शन एंड एक्सटर्नल फिक्सेशन. तो अगर इफ इट इज ओपन फ्रैक्चर जिसमें तुम्हें सॉफ्ट टिश्यू कवरेज अवेलेबल है, ठीक है, तो इसमें ओपन रिडक्शन की कोई जरूरत पड़ेगी क्या? नहीं, बस जस्ट डू अ क्लोज रिडक्शन एंड जस्ट इंसर्ट अ रॉड इनसाइड इट. ठीक है? और फिर क्लोज रिडक्शन कर लो और बाहर से एक्सटर्नल फिक्सेटर अप्लाई कर दो. ठीक है? तो क्लोज रिडक्शन एंड एक्सटर्नल फिक्सेशन कैन ऑल्सो बी डन इफ इनफ ऑफ सॉफ्ट टिश्यू कवरेज इज अवेलेबल. बट अगर मुझे इसमें से बेस्ट चॉइस रूल आउट करनी है, then the answer would be ORF. The reason is, याद रख लो, yes, in all intra-articular fracture or fractures of necessity, I require ORF. But the problem is, in a case of an open or a compound fracture, मुझे क्या करना पड़ेगा? पहले कुछ टाइम के लिए I need to give the patient antibiotic coverage. As the patient infection will resolve, then I will go for a ORF. It is not the emergency management. They have asked about what? That is the reason why I have changed my answer. They have asked you about the emergency management. Emergency मतलब at the time of fracture immediately तुम क्या करने वाले हो? तुम immediately भी internal fixation करोगे क्या? नहीं करते. fixation immediately. The reason is there is a lot of hematoma which can be formed. Second, there are high chances of infection in a case of open or compound fracture. So you try to avoid an internal fixation in the emergency management. ठीक है, अगर वो मुझे पूछते कि they would not have mentioned emergency, they would have just mentioned कि what is done for the management of an open fracture. तो उसमें or if would also have been an answer. मैंने जैसे बताया. But emergency management immediately at the time of presentation, will we do internal fixation? No, we will try to avoid internal fixation for some time due to the high risk of infection in case of open or a compound fracture. ठीक है, तो emergency की वजह से my answer would be what? My answer would be option E. अगर emergency नहीं mentioned होता तो चारों भी आंसर हो सकते थे तुम्हारे दिन. ठीक है, चारों करेक्ट हो सकते थे मतलब. चलो, question number 3 if I talk about, a child was brought to your OPD. The child was brought to your OPD. हाँ बोल. Graft if there is soft tissue coverage. अगर soft, हाँ, इंटरनल फिक्सेशन के बाद नहीं कर सकते हो. अगर तुम्हें लगता है कि इंटरनल फिक्सेशन की जरूरत पड़ेगी तब यूजुअली तुम ग्राफ्ट इमीडिएटली नहीं करोगे. ठीक है, तब बस ड्रेसिंग कर दोगे पेशेंट का या फिर बस स्किन सूचर्स कर दोगे. जब तुम्हें पता है कि वापस खोलना ही है, इंटरनल फिक्सेशन करना ही पड़ेगा, तो डेफिनेटली यू विल डू इट आफ्टर इंटरनल फिक्सेशन, usually after a span of at least when the fracture will unite. Usually at that time you will go for a soft tissue coverage. Initially तुम soft tissue coverage नहीं करते हो if you are sure that you might need what? You might need another surgery in this patient. ठीक है. Question number 3 की अगर मैं बात करूं, here we have a child who was brought to your OPD with complaints of what? With complaints of difficulty in walking and delayed dentition. Classical two important findings. On examination, wrist widening is present and the lab workup reveals what? The serum calcium levels are normal. The serum phosphate levels are low. Serum parathormone levels is high and serum ALP level is high. What is the likely diagnosis? What do you think? Difficulty in walking hai. That is what is called as, the child might have limp also. ठीक है, लंगड़ा के चलेगा या फिर चल ही नहीं पाएगा ढंग से. ठीक है, so there is difficulty in walking, delayed dentition. दोनों चीजें कहीं ना कहीं तो कोरिलेट कर रही है. पीडिया हो चुका है तुम्हारा, ऑर्थो भी हो चुका है, बताओ. शाबाश. रिकेट्स. प्लीज रिमेंबर व्हाई? बिकॉज बोन और टीथ दोनों में किसकी जरूरत पड़ती है? डिपोजिशन ऑफ मिनरल्स की, जिसको बोला जाता है मिनरलाइजेशन. बट हियर मिनरलाइजेशन दोनों का नहीं हुआ है, एंड डिक्रीज मिनरलाइजेशन ऑफ द बोन एंड टीथ इज व्हाट इज कॉल्ड एज रिकेट्स itself. Why I am saying it rickets and not osteomalacia? Because it has occurred before skeletal maturity. That means it is a child. Decreased mineralization of the bone before skeletal maturity will cause rickets. After skeletal maturity, it will cause osteomalacia adults mein. ठीक है, so my provisional diagnosis here is definitely rickets, and this is the classical finding of rickets: wrist widening. Please remember, usually when we do clinical examination, we'll try to palpate the wrist, and then you will find at the wrist there is widening of the wrist. Okay, that is due to what? So here you can see, this is a X-ray of rickets which has been given to you. क्या दिख रहा है? एपिफाइसिस दिख रहा है क्या तुम्हें? बोन्स का एपिफाइसिस नहीं दिख पा रहा ना ढंग से. So there is delayed appearance or absence of epiphysis. Okay, first feature that will be there is delayed appearance or absence of epiphysis. Second feature on X-ray which will be seen. Second feature, this is the important feature that is seen. क्या दिख रहा है? Wrist पे the radius and the ulna, both of these क्या दिख रहा है यहाँ पे? Both of them, they are widened up. Okay, metaphysis is widened up. Please remember this. ठीक है, और that is what is widening. Second क्या दिखेगा यहाँ पे? There is cupping. ठीक है, there is cupping. ये widening का दूसरा नाम क्या हो सकता है? It is also called as splaying. ये जो होता है ना, this is what is known as splaying. Then there would be cupping. And margins कैसी दिख रही है? Regular या irregular है? Irregular है. So irregular margins is also known as fraying. इसका metaphysis का. So cupping, splaying and fraying of metaphysis is the characteristic feature on X-ray of a rickets. Please remember, that's the characteristic feature. ठीक है, so cupping, splaying and fraying of metaphysis, that is usually seen, and delayed appearance or absence of epiphysis. These are the important features, diagnostic features rather, on X-ray of rickets in a patient. If I talk about serum calcium levels, yes, serum calcium levels can be normal in a case of rickets. Yes, they can be normal in some cases. Please remember. Okay, in majority of the cases they can be low, but in some cases, yes, the serum calcium levels can be normal, because for serum maintaining the serum calcium levels in your body, what is not only responsible, कि कौन सी तीन चीजें रिस्पॉन्सिबल होती है सीरम कैल्शियम एंड सीरम फॉस्फेट लेवल्स को मेंटेन करने के लिए बॉडी में? भाइयों, कौन सी? विटामिन डी। फर्स्ट ऑफ ऑल, विटामिन डी क्या करता है? इंक्रीज या डिक्रीज? It increases serum calcium as well as increase serum phosphate. Why? Because it increases the absorption of calcium and phosphate from the intestine. Second, it increases what? Sorry, it prevents excretion of calcium and phosphate, or it increases reabsorption of calcium and phosphate from the kidneys. Whereas third, it causes deposition of this calcium and phosphate in the bone, and that is what is called as mineralization of bone. So if a patient is having vitamin D deficiency, the patient will suffer from what? Decreased mineralization of bone. Adults में क्या होगा? Adults में there would be osteomalacia, and in children what will happen? There would be rickets. ठीक है? So what is the cause of rickets now? I hope all of you are quite aware. The cause of rickets is vitamin D deficiency. Please remember, there can also be vitamin D independent rickets. That's a different funda altogether. But vitamin D deficiency की वजह से mainly rickets will occur, and the most common cause is nutritional deficiency of vitamin D usually. ठीक है? या फिर a patient who is not living in a sunlight exposed area. ठीक है? So these are the causes. Or a patient suffering from liver or kidney disease, because skin, liver and kidney are the three sites where vitamin D synthesis will occur. ठीक है? याद रखना है बात. Second क्या था vitamin D के अलावा? पैराथॉर्मोन. पैराथॉर्मोन increases किसकी और decreases किसकी? जल्दी से. It increases serum calcium level but decreases serum phosphate levels. And third क्या था? मैंने तुम्हें पहले भी बताया था, कैल्शियम होमियोस्टासिस इज मस्ट. इट इज इंपॉर्टेंट. हमेशा क्वेश्चन है इस पे से. कैल्सिटोनिन की अगर मैं बात करूं, कैल्सिटोनिन क्या करता है? दोनों के लेवल्स को कम कर देता है. प्लीज रिमेंबर दैट्स कैल्शियम होमियोस्टासिस. एक टेबल याद करने में क्या हो रहा है? ठीक है? तो दैट शुड नॉट बी फॉरगॉटन. अभी ये टेबल कम से कम याद करना है. चलो, moving further now. Here the serum calcium levels are normal, serum phosphate levels are low. ठीक है? And serum parathormone levels is high. तो क्या हो जाता है? When vitamin D की deficiency होती है, तो patient will suffer from decreased serum calcium levels, hypocalcemia. उसकी वजह से किसको स्टिमुलस मिलेगा? पैराथायरॉयड ग्लैंड को, कि भाई पैराथॉर्मोन बनाना शुरू करो. दैट इज द रीजन व्हाई द पेशेंट्स पैराथॉर्मोन लेवल्स आर हाई. एंड जब पैराथॉर्मोन लेवल्स हाई हो जाती है, तो पैराथॉर्मोन क्या करता है? इट इंक्रीजेस सीरम कैल्शियम लेवल्स. सो पहले कम हो चुकी थी, अब इंक्रीज हो रही है. सो सीरम कैल्शियम लेवल्स वुड बी रिस्टोर्ड बैक टू नॉर्मल. अब समझ रहे हो? टू नॉर्मल हुई है वो. एंड ऑन द अदर हैंड सीरम फॉस्फेट लेवल्स को क्या करेगा? वो कम. लिखा है ना, सीरम फॉस्फेट लेवल्स आर लो इन द क्वेस. So that is due to this compensatory mechanism, due to increased parathormone production. Please remember. I hope no issues with this anybody. And serum parathormone जब secrete होता है, तो parathormone का काम क्या होता है? It will activate with cells of the bone. There are three cells in the bone. Bone forming cells called as osteoblast. Bone destroying cells called as osteoclast. And the bone mature bone cells called as osteocytes. Abundant osteocytes. If I talk about parathormone, तो यहाँ पे पेशेंट में ALP भी इंक्रीज्ड है. ALP कौन से टाइप ऑफ बोन सेल्स में होता है मेनली? Which bone cells are rich in serum alkaline phosphatase? Osteoblast. Please remember ALP is high in osteoblast. तो क्या दिख रहा है यहाँ पे? There is increased osteoblastic activity. तुम बोलोगे सर पैराथॉर्मोन एक्टिवेट हुआ है तो ऑस्टियोब्लास्टिक एक्टिविटी कैसे इंक्रीज हुई है? प्लीज रिमेंबर, पैराथॉर्मोन usually cannot directly activate the osteoclast. Parathormone कैसे बढ़ाता है serum calcium levels? By destroying the bone. It will damage the bone, it will cause bone resorption, और वो क्या करेगा? Bone से calcium उठा के blood में भेजेगा. That is what is known as bone resorption. तो उसकी वजह से क्या हो जाएगा? Bone weak हो जाएगा. Serum calcium levels will increase. But on the other hand क्या हो रहा है? Bone तुम्हारा खराब होता जा रहा है, bone weak होता जा रहा है. ठीक है? So usually osteoclast का काम होता है bone को destroy करना. But parathormone could not directly activate the osteoclast. तो उसको पहले किसको एक्टिवेट करना पड़ता है? It needs to activate the bone forming cells first. At low doses, parathormone activates the bone forming cells, that is osteoblast, and then further, due to the rank ligand receptor, then further the osteoclast will be affected, and finally क्या होगा? Bone resorption हो पाता है. So that is the reason why if you give parathormone in low doses, it will activate with cells osteoblastic cells, and therefore there would be bone formation. इसीलिए in a case of osteoporosis पढ़ा होगा ना, in a case of osteoporosis we give a parathormone analog known as injection teriparatide. That is the reason. Teriparatide is a low dose parathormone which will